the Senior Manager of Patient Education Programs here at the Lymphoma Research Foundation. It is my great pleasure to welcome you to our webinar, Update on Mantle Cell Lymphoma. During today's webinar, you'll hear from two expert speakers and you'll have an opportunity to ask questions. You can ask those questions at any time in the Q&A box at the bottom of your screen, and we'll aim to address as many as we can after the presentations today. And as a reminder, this webinar is being recorded. Also, at the end of the program, you'll be prompted to complete a program evaluation. Please do complete this brief evaluation as we incorporate your feedback into future programming. Before we get into the presentations today, I'd like to share with you a few brief words about our organization. The Lymphoma Research Foundation is the largest nonprofit organization that focuses specifically on lymphomas and chronic lymphocytic leukemia. Our mission is to realize the promise of science to eradicate lymphoma and to serve the community touched by this disease. All of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. In addition to today's program, the Foundation also has many other programs and services available for you and your loved ones. We offer both in-person and virtual programs so that you can continue your learning throughout the year. To view all upcoming programs, you can visit lymphoma.org/programs, but specifically, I did want to highlight our upcoming Living with Lymphoma program, which will be held on Saturday, November 8th. Living with lymphoma is an opportunity for patients to learn more about their specific diagnosis as well as supportive care topics. So the agenda for our upcoming program will include a breakout session on mantle cell lymphoma, as well as sessions on integrative oncology, coping during active surveillance, sexual health and intimacy, and long-term side effects. So if you'd like to view the full agenda and register for the program, you can visit lymphoma.org/livingwithlymphoma, and I will also send that link in the chat today during this program. In addition to our patient education programming, the Foundation also offers a wide range of support services. So our helpline has master's level trained staff who can provide individualized information on all types of lymphomas, as well as treatment options, clinical trial navigation, and connections to resources such as financial assistance. We also offer a peer support program called the Lymphoma Support Network, and through the Lymphoma Support Network, we can connect patients and care partners with others who have been through similar experiences for emotional support. The Foundation also offers a comprehensive disease guides and fact sheets, which can be ordered or downloaded for free on our website at lymphoma.org. And please look for us on YouTube as well, where we spotlight different lymphoma subtypes and treatment options. I'd also like to briefly take a moment to thank our program supporters. Thanks to their generosity, we're able to host programs like today's webinar. We have a wonderful program planned for you today. You'll hear from, again, two expert speakers, Dr. Julie Vos from the University of Nebraska Medical Center and Dr. Peter Martin of Weill Cornell Medicine, New York Presbyterian. I'm first so honored to introduce our first speaker, Dr. Julie Vos. Dr. Vos is a hematologist oncologist and the chief of the Division of Oncology and Hematology at the University of Nebraska Medical Center, where she's also a professor of medicine. Dr. Vos has been involved in oncology and hematology for over 30 years, and she's also a former member of the Foundation's prestigious Scientific Advisory Board. She's currently on the executive committee of our Mantle Cell Lymphoma Consortium, and we're so thrilled to have her on our program today. So thank you so much, Dr. Vos. I'll now turn the talk over to you.
Thanks so much. I appreciate that introduction. So I'm going to share my slides here. All right. Can you see those okay?
Still.
Okay, great. So my job today is just to introduce the topic of mantle cell lymphoma a little bit, talk about diagnosis, biomarkers, and then get into initial treatment a little bit, which has changed quite a bit over the last few years. First of all, how common is mantle cell lymphoma? It's actually not very common. This slide shows us the different, a pie with all the different types of lymphomas. And mantle cell lymphoma represents about 6% of all non-Hodgkin's lymphomas. It is more common in northern European areas and in the US as compared to Asian countries, for example. We unfortunately don't know what causes mantle cell lymphoma, and it's one of the many different subtypes of non-Hodgkin's lymphoma that this pie shows us. So it's an interesting lymphoma. It is present much more commonly in men than in women. So male to female ratio is about 4 to 1, again for reasons we don't understand. An average age of diagnosis is kind of mid-60s. Definitely in adults. It's not something that's seen in pediatrics. Most patients have advanced stage disease at the time of diagnosis, and involvement of the blood and bone marrow is quite common. Probably at least 30% of the patients have obvious involvement, and then probably more than that have microscopic involvement. B symptoms such as weight loss, fevers, night sweats are present in about 30% of patients. And it's very common that this type of lymphoma is in what we call extranodal sites. So that is in the blood, in the bone marrow, and a very, very common site with this type of lymphoma is in the gastrointestinal tract. So if you really look very carefully in the gastrointestinal tract of patients with mantle cell lymphoma, probably as many as 80% of patients have involvement to some degree. On the right-hand side of this slide, you can see that there's a picture of a colonoscopy of a patient who has mantle cell lymphoma, and these little balloon-looking type areas are lymphomatous polyposis, or areas that actually have involvement by mantle cell lymphoma, and this is quite common actually in our patients with mantle cell. Also, very interestingly, mantle cell is highly variable as far as the clinical course. Some patients it behaves very indolently, can be present for years and years without the need for treatment. And other patients, it presents in a very aggressive course where the patient's very, very ill, has lost a lot of weight, has very large masses, or areas that the lymphoma is involved in the lungs or GI tract or spleen, or in the brain or spinal canal. So it's highly variable in the way that this presents in patients. So as far as how the most common presentation, I just made up this hypothetical patient here for signs and symptoms. So a common patient presentation might be a 69-year-old male who presents with abdominal fullness. He has enlarged lymph nodes that have grown over weeks to months period of time, and extreme fatigue. On examination, he has enlarged lymph nodes that are about 2 to 3 centimeters, and he has an enlarged spleen. Lymph node biopsy would show us the mantle cell lymphoma after doing all the appropriate stains and studies. And commonly, a patient like this may have low blood counts, so a hemoglobin of 9, so anemia, platelets of 75, or thrombocytopenia, low platelets, and a high LDH, or lactic dehydrogenase. The LDH is a blood test that we check, and kind of helps us look at how aggressive the lymphoma might be. Typically, we would also do a PET scan on these patients, and they would have diffuse lymphadenopathy in this case, in this particular hypothetical patient, 3 centimeters, which is an enlarged lymph node, and also in this particular patient, splenomegaly, enlarged spleen. So this might be a PET scan of such a patient. So the patient has a very enlarged spleen. That's what this shows right here. This is the liver, and the spleen normally would be kind of the same color as the liver. It's very, very dark, meaning that it's involved with lymphoma. And then also the patient has scattered lymph nodes that are enlarged underneath the arms, in the neck area, in the groin area. Also, the patient has involvement of the bone marrow, likely with uptake kind of throughout the bones, you can see in many locations. And on this side is the other views from the PET scan, again showing very enlarged spleen and scattered uptake in the lymph nodes. So what do we do next? So if the patient hasn't had a diagnosis yet, and they would have a diagnosis of a lymph node and or bone marrow to make the diagnosis, flow cytometry is very helpful on the blood or the bone marrow, and FISH testing is often needed to make the final diagnosis. We would do the laboratory evaluation as mentioned, and then consider other tests depending on the symptoms for the patient. So if the patient has some symptoms of confusion or headaches or other things that may make us be considered that there's some of the cells in the spinal fluid, then you may want to do a lumbar puncture to check the cerebrospinal fluid. If the patient has GI symptoms, GI biopsies may be necessary, or other tests depending on the symptoms for the patient. PET scan, as we just showed. Pathology confirmation is important, looking at all the special studies. Percent Ki-67 is how we see how fast the lymphoma is growing, and also the different subtypes of mantle cell. A blastic subtype is also one of the more aggressive subtypes. Very important for planning our treatment would be a TP53 mutation should be performed on the pathology specimen to see if that's a mutation. That's a mutation that may tell us how aggressive the lymphoma is going to be and help us also trying to choose the treatment option for that patient. We calculate what's called a MIPI score, and that uses some very easy prognostic factors: age, performance status, that is how well the patient's able to do their normal activities, this blood test like LDH, lactic dehydrogenase, and then what the white count is. And using those very simple measures, the risk factors are calculated from 0 to 3 as far as the different points and the different categories for the patient. And this has been helpful over the years to help us decide kind of how aggressive their lymphoma might be. So MIPI prognostication into these categories has helped us to see there's some patients with pretty low risk disease, an intermediate risk disease, and higher risk disease. So we put this information together with all of the information we talked about earlier, the pathology, the type, the TP53 mutation, and all that's helpful in helping us prognosticate and also to choose which therapy we might think would be best for that patient. So looking at those risk factors, it is very biologically heterogeneous, and we need to risk stratify and help us to choose the different treatment options. So kind of on the left-hand side, the low-risk patients have a very low Ki-67. That's how rapidly the cells divide. And they have these other stable karyotype and other factors you can see here that typically behaves very indolently in the patient. In the middle is kind of classic mantle cell. That's where the majority of patients would be. And then on the right-hand side, what we call blastic mantle cell, where the patient has a much more aggressive disease. They often have this TP53 genetic mutation, complex karyotype of the abnormality, and a very high Ki-67 or cells that are dividing rapidly. So this helps us with prognosis, but also helps us in trying to choose which therapy would be right for the patient. So the original MIPI, as I showed earlier, and then adding on this Ki-67, or how fast the tumor multiplies, is helpful in trying to come up with what we call the MIPI-C, and that helps us to stratify these patients and to choose therapy that might be most appropriate. Choosing much more aggressive therapy for the high-risk MIPI-C, and perhaps a watch and wait or low intensive therapy for the low risk patients. So what are the considerations for treatment choice? Well, what symptoms is the patient having, and or are they having any? Sometimes the patient's asymptomatic and they just were diagnosed by a blood test, or sometimes they have very small enlarged lymph nodes that are seen. What is the location of the mantle cell in the body? For example, if the patient has confusion and we do an MRI and a lumbar puncture and find that the mantle cell lymphoma is involving the brain or spinal fluid, that would be very different potential for treatment options as compared to just in the lymph nodes and small volume. Of course, we need to consider the age, physical condition, and other medical conditions for the patient. So a patient who is younger, in their 50s, and otherwise good physical shape, we would perhaps choose a more aggressive regimen than a patient who's in their 80s and has a lot of other medical illnesses such as heart problems, lung problems, neurologic problems. That may be an entirely different choice of therapies and different conversation. Also, again, choosing a therapy based upon some of the subtypes we talked about, such as the blastic morphology, might have an increased risk of mantle cell in the brain. Also, this molecular testing we talked about, does the lymphoma have a TP53 mutation on molecular testing? And if so, typically a choice of therapy that includes a BTK inhibitor, Bruton's tyrosine kinase inhibitor, may be a good choice as well. And those are medicines that typically was in the past used for relapse patients, but now are being used much more commonly for upfront patient treatment as well. So just historically, we've always used pretty intensive therapy for younger patients with mantle cell lymphoma. So this is a very long follow-up, 15-year follow-up on a study that was done quite a few years ago, mostly in Europe, called the Nordic regimen. And it's a very intensive, short chemotherapy that patients underwent for mantle cell. And you can see that the way to read this is percentage of progression-free survival, that is patients that are alive and in remission, and this is years after their treatment. So you can see here that starting out with 100%, out here at 8 to 9 years, you still have 50% of patients who are in remission, alive and doing well, and have no signs of relapse. But even over time out here to as far as kind of 15 years, you see that the lymphoma continues to relapse. So in some patients, unfortunately, this does relapse at a very late time frame, so patients need to be followed for basically indefinitely after their treatment. So this brings us to treatment that was maybe a few years ago. This was kind of the standard of care for first-line therapy. Induction therapy for patients who were considered eligible for stem cell transplant, that is, they could undergo an aggressive regimen, typically underwent an induction therapy and an autologous stem cell transplant in first remission if they were able to. For patients who were felt not to be, then they underwent a less aggressive regimen. And then second-line treatments were these BTK inhibitors, Bruton's tyrosine kinase inhibitors, which are oral medications, as well as potential for lenalidomide. Rituximab anti-CD20, of course, was used in all lines of therapy. And then third line of therapy was CAR T-cell transplant, which Dr. Martin, I'm sure, will get into a little bit later. But several studies that have been done over the last few years and published have kind of changed how we think about the first-line treatments. So I'm just going to present some of the more recent studies. So one study that has a little bit more recently been presented was the SHINE study. And this took bendamustine Rituxan, which is a chemotherapy and immunotherapy. It used to be a very good standard of care induction for this patient population, and added ibrutinib, which is a Bruton's tyrosine kinase inhibitor that was the first one on the market. And what they did was compared the standard of care, so BR with a placebo, to BR plus ibrutinib. And what they found in this study was that the patients that were randomized to the addition of the ibrutinib to the BR did have an improvement in what we call progression-free survival. That is, more patients were alive and free of disease at various different time points after the treatment. This is a fairly short-term follow-up due to the relative recent part of the study. However, if we looked at overall survival, that is, how many patients were alive at 7 years after this treatment randomization, it was about the same, and the statistics didn't show any difference. So what that means is that patients who were in the control arm and didn't get a Bruton's tyrosine kinase inhibitor could have that treatment or other treatment as a second treatment and still have the same outcome, have the same survival with respect to the patients who had it in first-line treatment. So, so this is a little controversial yet, but I would say many patients are now receiving the Bruton's tyrosine kinase inhibitor as part of their first treatment, based upon this information. And this is what I talked about. The overall survival was actually no different at the time this was reported, 57 versus 55%. There are certainly toxicities with BTK inhibitors, and I'm sure Dr. Martin will get into a lot of these later too. Another similar trial added acalabrutinib, which is a second generation BTK inhibitor, also to the bendamustine rituximab. Similar design for the study. They also found that progression-free survival, that is alive and free of disease, which was the primary endpoint for the study, had an improvement at the median follow-up of 45 months, but this study also showed there was no difference in overall survival. So similar to the SHINE study, just using a different BTK inhibitor. Another study that I want to bring to your attention is called the BOVIN study, and this is using zanubrutinib, another newer generation BTK inhibitor, with obinutuzumab, which is an anti-CD20 monoclonal antibody, and venetoclax, which is a BCL2 inhibitor given orally. And this was a study, had a lot of different patient populations, but for this purpose, looking at the mantle cell patients, in particularly the patients that had a TP53 mutation, that mutation that's difficult to treat, the patients on this were given this regimen and studied on this particular study. And the reason for that is that patients with the TP53 mutation are relatively chemotherapy insensitive and don't have nearly as good of outcome with chemotherapy as compared to other types of therapies such as BTK inhibitors. So this is a fairly recent study, so not very long follow-up, but they did see that the patients had a very good complete response, that is no signs of the disease after the treatment was finished, and the overall response, that is complete response plus partial response, was close to 100%. They also measured what's called minimal residual disease and found that many of the patients had no evidence of minimal residual disease, particularly after 13 cycles of this therapy. So this is a promising therapy, especially for those patients with the TP53 mutation. And then the triangle study, which also was presented a few years ago and more recently published, took patients who could undergo aggressive therapy, and this was in the era of the transplant being the standard of care. And they took a standard induction regimen that was used in Europe. This was mostly done in Europe. Patients were alternating to R-CHOP versus R-DHAP, which are different standard chemotherapy regimens. And then 2 of the arms of the study underwent autologous stem cell transplant with the addition of ibrutinib, the first generation BTK inhibitor. 2 of the arms also had ibrutinib maintenance, so you can see there was 3 arms, and then they were observed after that time period. So the bottom line for the study was, again, on failure-free survival, alive, free of disease. The patients who were in the 2 ibrutinib arms appeared to do better than the patients that had the autologous stem cell transplant alone without ibrutinib. Overall survival at the time of initial evaluation was not statistically different, however. Of course, all these therapies have toxicity, and ibrutinib was not shown to increase the toxicity of the chemotherapy. There were serious infections after autologous transplant, particularly in those patients who did have the ibrutinib. So their conclusions were that ibrutinib during induction and for 2 years of maintenance following transplant had the better outcome as compared to those patients with transplant alone. And this is continuing to be followed up with further follow-up, of course. But this all leads us to what we call the NCCN guidelines. Those are guidelines that all the physicians use. These were developed by National Cancer Institute hospitals and medical centers such as ours. And we have people that come together at least twice a year and try to update these to take into consideration new studies, as we just talked about, and how those should change the recommendations. So in this case, for mantle cell lymphoma, we're looking at patients who have early stage disease or more indolent disease as having specific recommendations as compared to those patients who have more extensive disease and but wild type TP53, that means it's not mutated, And then on the right-hand side, we have more extensive disease, but with that TP53 mutation. So this goes through a lot of the different recommendations, and what's right for one patient may not be right for the next patient. You have to take into consideration what their underlying health is, if they have other comorbidities, those sorts of things, and then try to specialize the treatment exactly for that patient. But these are recommendations based upon a lot of the studies that I just showed you. And again, it might not necessarily be right for one patient. What's right for one patient might not be right for the next patient. So have to take into consideration a lot of that issue. And then based upon a lot of those studies, the BTK inhibitor for a 2-year maintenance is also potentially recommended, as well as rituximab maintenance after treatment, which I did not go over those studies, has also been found to improve the outcome for patients. But in the end, it needs to be individualized for each patient, and that's why you come to see us, the lymphoma experts, to be able to do that. So in a little bit of a simplified fashion, newly diagnosed mantle cell, looking if it's indolent, it has that TP53 mutation or other high-risk features. If it's indolent, it can be observed for a while, and then eventually the patient will likely need therapy. We also look at chemotherapy plus the BTK inhibitor, chemoimmunotherapy, looking and see if the patient has a minimal residual disease positive after that. They still may be appropriate for a transplant and rituximab maintenance. If it's negative, which many of the patients are, maybe just rituximab maintenance plus a BTK inhibitor. And so individualized approach is really the bottom line. Thank you very much, and I'm going to turn it over to Dr. Martin, and then we'll be able to answer questions later. Thank you.
Thank you so much, Dr. Moss, for getting us started with the current frontline treatment landscape. I am now thrilled to introduce our next speaker, like you said, Dr. Peter Martin. Dr. Martin is a hematologist oncologist at Weill Cornell Medicine, where he is a professor of medicine and the chief of the lymphoma program. Dr. Martin is also a current member of the Foundation Scientific Advisory Board, and he's the chair of our MCL consortium. We're so happy to have him back for another patient ed program. So thank you so much, Dr. Martin, and I'll now turn the talk over to you.
Thanks very much, Hope and Dr. Vose. Can you hear me okay? Yep,
Yes.
good. So I'm going to carry on where Dr. Vose finished, and I'll talk about management of previously treated mantle cell lymphoma. I'll show some data. Some of it people may be familiar with, some of it may be a little bit confusing, and I think the question and answer period might be helpful. This is sort of a different view, basically, of what Dr. Vose showed, which is sort of the development or evolution of mantle cell lymphoma management over time. And what I really want to focus on is, the far right-hand side of this period, where you can see there's really been almost an exponential growth in the development of new drugs in mantle cell lymphoma for a whole bunch of reasons, in part because I think there's renewed interest in it. There's a recognition that there's an unmet need, and there's this kind of explosion of scientific knowledge and the understanding of lymphomas in general that has allowed people to develop new drugs. And I think it's really changed the way we see mantle cell lymphoma and the way people with mantle cell lymphoma experience life, which is a great thing. Probably one of the biggest impacts that's happened is sort of the development of immunotherapies, number one, and targeted drugs. Targeted drugs are sort of clever ways to figure out what's going on inside the cancer cell and develop drugs that target those specific processes. And these are all different immunotherapy and other enzymes that are on or inside the cell that have been targeted for mantle cell lymphoma. And we'll focus on just a few of them because we don't have time to talk about everything here. Specifically, we'll talk mostly about Bruton's tyrosine kinase, which is sort of in the middle of the slide here. And you can see that its role is basically to transmit a signal from the surface of the cell through a long cascade of enzymes to the nucleus of the cell that gives the cell signals to grow and divide. And by interfering with that signaling process, the cell essentially loses those stimuli and stops growing and dividing, and in fact goes on and dies. Ibrutinib was the first drug that was approved, the first Bruton's tyrosine kinase inhibitor that was approved for mantle cell lymphoma in 2013. And it was approved really based on one trial, this PCYC 1104 trial. There were subsequently three separate trials that did have a single agent of ibrutinib in at least part of the trial. And I put them up here for a couple of reasons. One is to show basically all three trials showed that they were active, clearly active, in people who had had multiple prior therapies. So typically lots of different kinds of chemotherapy. The other thing that I think is important is you'll see that although the activity is pretty similar in terms of overall and complete response rates in all three clinical trials, there are differences, and including the differences in what we call progression-free survival, or PFS. That's the time from the start of the trial to the time that the drug stops working, essentially. And you can see that in one trial, this middle trial, that was about 10 months, and this other trial, the Ray trial, which is a big trial, it was 50% more than that, despite the fact that the patient populations being targeted for those trials were quite similar. The reason I like to show this slide is simply because there's a tendency amongst all of us, including those of us who work in academic medicine, to look at two different trials and say, well, this drug looks better than this drug. But you can see that even when you look at the exact same drug in more or less the same patient population, there are going to be differences in outcomes in different trials for reasons that are difficult to explain or measure. And it's important to keep that in mind when those of you who are maybe more data-driven or scientifically savvy are looking at papers on the internet and saying, well, this drug looks better or worse. Just be careful comparing between clinical trials, because as hard as we try, it's not always easy to do that. One of the things that we learned by pooling all of the data from those people, over almost 400 people treated with ibrutinib on those three trials, is that it works better in some people than other people, which is, I think, predictable. And this is a graphical representation of that. In the middle, you'll see this line that goes up and down around 1. That represents more or less the average time to progression in this case. And you can see that the dots that are to the right of that curve represent a higher risk of progression. So people who have characteristics like that maybe don't do quite as well with ibrutinib by itself. Keep in mind, this was a population of people who were pretty heavily pretreated with a lot of chemotherapy. But in that population of people, these were the findings. And it's not entirely surprising that people who had various high-risk features, including the MIPI score that Dr. Vose mentioned, including the blastoid histology, which is a very proliferative tumor or often has a very high Ki67, what Dr. Vose also mentioned, maybe don't do quite as well with ibrutinib. I'm going to come back to that point in the future. So what are some of the ways that we might improve upon ibrutinib? Well, one of the first ways that people decided might be better would be to develop sort of these quote unquote me too drugs, which are drugs that are very similar to ibrutinib that also inhibit the BTK enzyme, namely acalabrutinib and zanubrutinib. You can see in the graphs on the top, or the figures on the top, that these drugs were more specific to the BTK enzyme. You see fewer red dots, and they're more focused than they are on the ibrutinib side, where the drug was inhibiting more enzymes. I'll make a couple of other points here. One is that all three drugs were initially approved based on accelerated approval. This means that they were approved based on relatively small single-arm trials, and that full approval is only now granted for acalabrutinib on the basis of the ECHO trial that Dr. Vose mentioned, where acalabrutinib was combined with bendamustine and rituximab. Full approval for zanubrutinib is pending the results of a large phase 3 trial. Ibrutinib, in fact, was not granted full approval and was actually withdrawn from the market for mantle cell lymphoma. It's still available for other lymphomas. The other thing that I'll mention, just at the bottom, you can see the cost of these medications. These are extremely expensive medications, again, for a whole variety of reasons, not all of which are rational. And this is going to have an impact somewhere down the road, likely, at least in some countries. These are what we call adverse events or safety data. And these are some of the most significant kinds of side effects that somebody might experience while taking these drugs. You can see that they're not very common, but when we look at the things that might be most common, we see infections. Now, some of this is just the nature of lymphoma. Some of this is the nature of having had multiple prior therapies for lymphoma, but some of it is related to these drugs. When we look at really serious side effects, in general, they're pretty rare, and they're also pretty similar between all three drugs. There may be subtle differences that we don't see in this table, but for the most part, they're quite similar. So I mentioned that it would be great if we could improve upon ibrutinib. One way to do that is, as I said, to develop newer versions of ibrutinib. Another way is to combine BTK inhibitors with other drugs. And there have been multiple attempts to do that, probably literally dozens of trials. This is probably the most famous combination, probably because it's the most successful combination, and it's the combination of ibrutinib plus another targeted drug which inhibits an enzyme called BCL2, and that drug is called venetoclax. This was a trial that was performed in Australia, and it was again in people who had previously treated mantle cell lymphoma. It was a small trial, just 24 people. You can see the characteristics in the bottom left corner, and these were by and large a very high risk population of people. But you can see on the top right that despite those high risk features, the responses were overwhelmingly positive. And in the bottom right, this is what we call MRD, or minimal residual disease, a very sensitive way of picking up even one in a million cells, or in this case, I think the most sensitive test was 1 in 10,000 cells. So very few cells floating around can be picked up by this assay, and this combination was very effective at eradicating or making these cells undetectable. So it was a clearly very active combination, and that resulted in a phase 3 trial called the Simpatico trial, again in people with previously treated mantle cell lymphoma. And in the trial, people received either ibrutinib, which is still to this day remains a reasonable option, or the combination of ibrutinib and venetoclax. You can see that the overall and complete response rates on the bottom left were higher in the combination, and the progression-free survival, the average time that the drug worked, was about 10 months longer in the people who were randomized to receive the combination. So 10 months better, but it comes at a small cost. And that's where we look at the safety data again. On the left side, you can see these are more of the serious side effects. And between the two groups, there, in fact, were very few differences if we look at the serious side effects. On the right side, however, you see some of the more frequent side effects. And what you see are differences in rates of mild side effects like diarrhea, small changes in blood counts. And ultimately, what that means, I think, is that this impacts, to some degree, some issue of quality of life. So while people are taking the drugs more successfully for a longer period of time, they're probably also experiencing a few more side effects or requiring a little bit more monitoring than they might be if they were receiving just one drug on their own. And so when we make these decisions to use single drugs or combinations, we have to take into account not only the good, but also the potential bad issues that might arise from any combination. Another way to improve upon a BTK inhibitor is to, in fact, make the BTK inhibitor work a little bit differently. And now this is a little bit of a fancy schematic, but the sort of spirally structure that you see in the back in the middle is this BTK as a representation of the BTK enzyme. And the C481 is an amino acid in the enzyme that can be mutated in some cases. And when it's mutated, it prevents the drugs like ibrutinib, acalabrutinib, and zanubrutinib from binding. This is the sort of teal-colored drug that's on the far right-hand side. You can see that it's got this little arm that sticks down to the C481S and binds to it, or C481. When C481 is mutated and becomes C481S, that drugs like acalabrutinib, zanubrutinib, ibrutinib no longer will bind to the BTK enzyme, Pirtobrutinib, however, is a drug that does bind. That's the sort of maroon figure in the middle of the of this graph or figure. And so in the context of a C481S mutation, pirtobrutinib can bind to the BTK enzyme and still inhibit it successfully. Now, it turns out C481S mutations are very common in some lymphomas, particularly chronic lymphocytic leukemia. And although they exist occasionally in mantle cell lymphoma, we've reported a few cases of it. It's pretty rare. In fact, there are probably other much more significant mechanisms of resistance to standard BTK inhibitors than this particular mechanism of resistance. So the rationale for using pirtobrutinib may not be as strong in mantle cell lymphoma as it is in something like chronic lymphocytic leukemia. Nonetheless, it is still active. In a big clinical trial called the Bruin clinical trial, there was a large cohort of people with mantle cell lymphoma, mostly having received a prior BTK inhibitor, 14 of which had not received a prior BTK inhibitor. And on the bottom right-hand side is what we call a waterfall plot. And it basically graphically represents the change in the size of lymph nodes. And the blue bars represent people who had been on a different BTK inhibitor, and then the lymphoma started growing. And you can see that they're sort of evenly split between both groups. The people with the red bars had been treated with a BTK inhibitor but had to stop due to some sort of side effect. And overwhelmingly, they seem to do quite well. So pirtobrutinib may have a role in mantle cell lymphoma, although its role in people who have been on a prior BTK inhibitor and it stopped working, there may be a little bit less rationale than somebody who stopped because they weren't tolerating one of the other BTK inhibitors. That led to what is this ongoing phase 3 trial comparing pirtobrutinib to other BTK inhibitors, and we don't yet have the results of this trial, but it's eagerly awaited. I'll just quickly mention that there is a new version of drugs targeting BTK. These are called BTK degraders. There are several of them in development. Many of them are showing early signs of activity, but I don't think we have enough information to say how well they're going to work, where they're going to fit in mantle cell lymphoma or other lymphomas. The other last approved drug that I'll talk about quickly are CAR T cells as a class, and there are really two of them that are approved for mantle cell lymphoma. The first one was called axicabtagene ciloleucel. It was approved in this trial called ZUMA-2. Many of you may have heard of these. These are almost like science fiction type treatments. They're basically you can see there's sort of a description of what happened. So people were enrolled in this trial and their blood was collected, specifically their white blood cells were collected. And that was sent off to a factory where their white blood cells were engineered to fight against lymphoma cells. Basically, this protein that you see on the far left was inserted into the cell and it can bind to lymphoma cells and kill them. That process typically takes 2 to 3 weeks. In the context of this trial, it was about 16 days. That's pretty typical, maybe a little bit faster than we experience in real life, but pretty similar. In that period of time, people could receive other treatments, and then they received a small dose of chemotherapy, fludarabine cyclophosphamide. The T cells were infused back into people, and they typically would stay in the hospital for about 2 weeks on average, sometimes a little bit less, sometimes a little bit more. And that worked remarkably well. Over 90% of people had a response to that, including over 60% of people where the lymphoma was no longer detectable on imaging. And in people who achieved a response like that, it lasted on average for about 3 years, despite having been fairly high risk, as you can see from this table on the left-hand side. Lysocabtagene maraleucel is the second CAR T cell product that was approved for mantle cell lymphoma. This is a busy slide, I apologize. But what I'll say is that there's a general feeling among people who use CAR T cells frequently that lysocabtagene maraleucel may be a little bit easier or better tolerated in some cases, and so it's sometimes used in cases where a person might be a little bit older or more frail or less likely to tolerate some of the more significant side effects from axicabtagene ciloleucel. Again, there are no head-to-head clinical trials, so it's difficult to say something like that conclusively, just sort of a gut feeling or a hunch. The last class of drugs that I'll mention quickly are these drugs called bispecific antibodies. These are exciting treatments that are being studied basically across the board in oncology. There are already some of these bispecific antibodies that are approved in other cancers, and specifically follicular lymphoma and diffuse large B-cell lymphoma. Different antibodies approved in other cancers, and for example, multiple myeloma. These drugs are all being evaluated in mantle cell lymphoma, and I'll just show you a little bit of data quickly. Probably the most exciting or well-known trial is a trial published by our colleague Tysel Phillips from City of Hope, looking at glofitamab in mantle cell lymphoma. All of these drugs share certain characteristics in that people will typically get some sort of pre-treatment, in this case obinutuzumab, very often steroids, and then the dose of the bispecific antibody is slowly escalated 1 week at a time over 3 or 4 weeks until a full dose is administered and continued on for various periods of time, sometimes for 1 year, sometimes indefinitely. In this case, it was up to 1 year of treatment. And you can see, in the middle, I wrote the overall and complete response rates very high, again, in a fairly heavily pretreated population of people. That said, not all of them had received prior BTK inhibitors, so this is maybe not representative of where we might use these drugs most commonly in clinic right now, which is important to keep in mind. So probably this population of people with previous BTK inhibitors more representative of where we might see this drug used initially. But you can see that it did work quite well in this population of people. Based on the results of this clinical trial, glofitamab was put into the NCCN guidelines that Dr. Vos mentioned. It is not, however, approved for mantle cell lymphoma. It's approved for diffuse large B-cell lymphoma. And these guidelines suggest that it could be used in what we call an off-label setting, although there's no guarantee that insurance would necessarily cover it. This has led to the promising results from that trial, generated this GlobeRight trial, which is an ongoing phase 3 trial that will attempt to potentially have glofitamab approved in mantle cell lymphoma. We don't have the results from this trial. It's a challenging trial to do, so it may be a few years still. Lastly, I'll just quickly mention that a combination of a bispecific antibody called mosunetuzumab with another special kind of immunotherapy called polatuzumab. It's this kind of small thing on the bottom left, which is another antibody that binds to lymphoma cells, and these red ellipses are basically some sort of toxin. So polatuzumab is a clever way to deliver a toxin directly to the cancer cells, sparing most of the other cells in the body from the effects of the toxin. So it's a clever combination of two different kinds of immunotherapy drugs used together. And it was, again, in a small number of people, it was surprisingly effective and actually also very well tolerated. And I think there's a lot of interest in where this combination might go forward in the future. I'll just quickly mention a few quality of life concerns that I think are important when we think about which drugs we're going to use and when. And one of the challenges I think that we face in general is that although we have, an overwhelming amount of data to sift through in terms of which drugs are working and what their side effects might be, we have, in fact, very limited understanding of what people might prioritize, people who are in the process of determining which combinations might be applicable to them, which ones they're most interested in. As a research community, I think we're in the process of coming to terms with the fact that we need to start asking people what their feelings are and evaluating their personal experiences in the context of clinical trials so that we can understand the patient experience. And these include quality of life, or QOL. You'll see that evaluated as QO, or abbreviated as QOL. And so that I think we're going to see more of it in the future. It can be challenging to distinguish between lymphoma-related symptoms and treatment-related side effects, but all of these things need to be taken into account when we're selecting therapies. Interestingly, there can be discrepancies between what physicians and patients or caregivers prioritize as more important. And so this really comes down to communication. It takes a long time to discuss the management of mantle cell lymphoma with people and who have the lymphoma and their caregivers. And I think as physicians, we need to be soliciting information back from them. Increasingly, I think we're going to be asked to compare sort of short-term significant side effects like autologous stem cell transplant or CAR T cells to other kinds of treatment that might have milder but longer lasting side effects like BTK inhibitors or bispecific antibodies. And it can be relatively straightforward to compare two different BTK inhibitors, but it can be very difficult to compare two treatments that are very drastically different in terms of their side effects. And it's not always clear how best to do that. I think mantle cell lymphoma, as Dr. Vose mentioned, is a pretty heterogeneous lymphoma biologically, and its approaches as well. The approaches to caring for mantle cell lymphoma can be pretty confusing. And as I mentioned, financial issues are going to become increasingly relevant. I think we're all acutely aware of that right now, and it's going to continue to grow into the future, particularly since these drugs are becoming more expensive. So I'll stop there, and hopefully we have time for questions.
Thank you so much, Dr. Martin. Like you said, we're going to jump into some questions with the rest of the time we have left. Of course, we won't have time for all of the questions, but I'm hoping to combine them where I can so we can hit the major buckets that I know so many attendees are curious about. So I'm going to start with a question for Dr. Vos. We got a few questions about MRD. So to kind of summarize all the questions, first, how does MRD differ from a PET scan to confirm remission or no evidence of disease? And is there any merit to periodic MRD testing to either give a heads up to a relapse or as a confirmation that all is well?
So MRD testing is relatively new, but it is something that we're starting to use more and more in all our different lymphoma types of treatments. So that's where we take a sample of the tumor and do a molecular analysis or a gene sequencing of the lymphoma. And then at a later point in time after the patient's done with treatment, we would check their blood and our bone marrow to look for that genetic sequence. And the current MRD assay that's clinically available is called clonoSEQ, and that is an assay that has a certain level of sensitivity. So if there's less than 1 in 10 million cells there, it's not going to detect it because it doesn't detect enough in the blood after treatment. So it's used as an adjunct to our treatment, but in this case, most likely it's used to see if you want to go on to autologous transplant after an induction regimen would be the biggest place that I would use that right now. So it's definitely not a perfect test, unfortunately, but I think it's a move in the right direction, and newer types of MRD assays may be more sensitive. So I would use it as an adjunct to all the other testing, but not necessarily as a be-all, end-all.
Thank you, Dr. Vos. And Dr. Martin, the next question here for you is, since I was treated, it has been 12 years with no evidence of disease and no relapses, but does it become less likely each year that my lymphoma will return?
That's a great question. I don't think we know the answer to it. There's certainly an increasing concept that there are maybe some people with mantle cell lymphoma who may effectively be cured with their initial therapy. Ultimately, it's something that's difficult to know for sure. As Dr. Vose mentioned, essentially, I think we're committed to following people with mantle cell lymphoma for the rest of their lives. But I think there is increasing reason for hope that some people may never experience their lymphoma coming back.
Thank you. And Dr. Vos, one patient was wondering, does radiation have a place in the treatment for MCL?
Radiation is definitely occasionally used in MCL if the patient has a relatively localized MCL, as best we can tell, or if perhaps it's an older patient who can't take a lot of the aggressive treatments that we're talking about, but has one place that's clinically a problem, causing pain or bleeding or something else. So radiation could have use for sure. So yes, in individualized patients, it may have a place.
The sonography considered an improvement over venetoclax.
Can you repeat that again? Hope I think we.
Yeah, sure. For a relapsed MCL, is sonrotoclax considered an improvement over venetoclax?
Hmm. Sonrotoclax is a Bruton's tyrosine kinase, or pardon me, a BCL2 inhibitor that's in development, very similar to venetoclax. Neither of them are approved for mantle cell lymphoma yet. Venetoclax, as I showed, is clearly active in mantle cell lymphoma. I'm sure that sonrotoclax will be as well. I'm not maybe either I'm smart enough or I'm too smart to be able to say which one is more going to be more active. I think all of the time it happens to us where we're pretty convinced we know the answer to something and clinical data prove us wrong. So we'll wait and see. But it's great to have options. I will say that.
Thank you so much. Dr. Vos, this will probably be the final question for you. We have one patient here who says, if you're on zanubrutinib and rituximab as first-line treatment for mantle cell, if you don't have a complete remission, do you stay on it longer?
So if you have a partial remission and don't have a lot of symptoms, but it's still working, then yes, you would go ahead and stay on the zanubrutinib kind of indefinitely as long as it's helping. We're not expecting those patients necessarily to have a complete remission. We're just trying to control the disease. So that's an excellent controlling measure as long as there's not a lot of side effects from the treatment.
This gene translocation in mantle cell lymphoma.
Hope I think we lost that. Your audio is kind of tricky.
Oh, sure. Um, is there any research being done on what causes gene translocation in MCL?
Good question. I have a particular interest in this. Dr. Vose mentioned we don't understand why mantle cell lymphoma is more common in men than women, for example. Um, effectively all mantle cell lymphomas have a translocation that involves the cyclin D1 gene and on chromosome 11 and the antibody gene on chromosome 14. Translocations involving the antibody gene are very common in lymphomas. In general, we do understand why that happened because the antibody gene is important to all B cells. Why specifically it might happen more frequently in some diseases or others is unclear, and why cyclin D1 is another question, which normally isn't active in B cells, and why it's more common in men than women is another question. And I think we have some ideas, but I think for the most part it is a mystery why mantle cell lymphoma starts. It's not like other lymphomas, some other lymphomas where we do have clear associations with certain viruses or exposures or whatever. Mantle cell lymphoma is a little bit of a mystery.
All right, well, thank you so much for your insight on that question, regardless. And before we wrap up officially, I just want to thank Dr. Martin and Dr. Vos again for their time today. And I'd also, of course, like to thank our attendees for joining us for today's program. Please remember, if you have any additional questions or if you'd like to be connected with someone else who's been impacted by lymphoma, you can always reach out to our helpline. That number is 800-500-9976. And if you prefer email, that's helpline@lymphoma.org. And if you didn't get a chance to jot that down, you can visit our website, lymphoma.org, and you can find that information pretty much anywhere. But with that, thank you again, Dr. Vos and Dr. Martin. I hope you have a great rest of your day.
Thank you.
Help.
Take care.